I really thank you very much, the organization. I thank you very much, Ingolf, of course, for organizing all this, because it's really his efforts which made this possible. And I had in the red a short add to the title, treatment, because I think that today we need to talk about treatment, and I will present at the end some pragmatic clinical trials that we are doing using robots and using also sensor and in some way also AI. Let's see which is there to go. Okay. I start with a general introduction about sensors, robots, and I add telemedicine because it's very important to know that when you deal with technological approaches to any type of disease, telemedicine is very important because it's a way of monitoring also the results of your treatment in remote, so at distance. And it's convenient, it's accessible, it's cost-effective, if you well organize it, of course, and gives some comfort and privacy to the patients. The AI is basically the glue keeping together all these technologies. And after that, I'll go to the practical application of what is possible to do, at least at our times today. Maybe in the future, it will be possible to do more. But what we can really concretely offer to our patients, and this is what is in part of the objectives of the ECRA, so have adequate infrastructures, provide access to patients who are willing to participate in research projects and clinical trials, give them an up-to-date on what is possible to do now and what are the really possible to do clinical trials. And this is a quite simple slide showing that there is a close interaction between AI, robots, and sensors, which is in both ways. So actually what we collect from sensors enable robots to work better and give information to AI, which in turn give back this information to robots and to sensors themselves, so that robots can actually act as physical agents, executing tasks, and hopefully in the future treating patients from the rehabilitation standpoint. So what is a sensor? Sensor is anything that basically we can use, like cameras, laser light detectors, infrared detectors. We use a lot of gyroscopes, accelerometers, pressure sensors, and they allow us to collect real-world data. So basically, all the neurosensorial possibilities, that a person has, vision, hearing, pressure, sensation, motor, movements, and all can be recorded by appropriate sensors. And the AI, again, is a glue, which can interact with this information. And robots then may act using this information. Now there is, really a huge amount of possibilities and of different robots, sensors. It's a kind of a mess, I think. It's important to also to point out that video games, the gamification is important because it gives, it involves the patients. Particularly the older patients like to be involved with gamification. And virtual reality as well, because it has also to do something with the cognitive part of rehabilitation. And again, the importance of telemedicine, because the practice of telemedicine is, may enhance, it's difficult now to do it, but it may enhance in the future the connection between doctor and patient, leaving the patient in his or her own environment, and also deliver healthcare at distance and monitor the patient's state. And actually, it's not new. Willem Einthoven won the Nobel Prize for recording heart activity and sending it through a telephone cable. Now we don't have it, we don't need telephone cables, we have the Internet of Things. So we basically have a core, which, you know, connect us with everything and everybody in the world. It was for me very strange, you know, to understand and to learn this. I remember once, the very first time I went to the Mayo Clinic for working, I sent my project to Italy through the fax, which was already enough, you know. Now we have, you know, an incredible opportunity of sharing knowledge, things, information, and of course, sensors are very important in this condition. And as a matter of fact, the literature is strikingly increasing in the last years regarding this, you know, keyword, very general keywords like neuroplasticity, gait disorders, rehabilitation, robot-assisted, and so on. But of course, we must take account of the patient-related issues. It's not just a matter of technology. It's a matter of being able to interact with patients, having the consent to sharing data. Of course, it's important, you know, all around Europe, but the world. Mobile technology and data collection, there should be a reliable interface, and not everybody has a reliable interface. You know, I'm 68, actually 69, so I'm part of I needed to learn the technologies, and most of our patients are actually older than 69 years. So the knowledge, the formation, also the didactic of this is very important. So there are pros and cons, of course, like almost in everything, I would say, in medicine. So what are the pros? Well, the pros are that we can enhance patient care and support healthcare practitioners. We can increase the amount of therapy that the patient, for example, being wise in using robots, one physiotherapist could treat 3, 4 patients at the same time. So save person from, you know, and treat more patients. Enable telerehabilitation, again, is very important to treat the patient at home, as I said before. And particularly engage patients. Do you have some water? Because, you know, with this flu, I almost can't speak. Okay. Okay, thank you. And the cons. I mean, the utilization remains very low because it is, you know, maybe very, very costly. I mean, it may cost a lot of money. The limited adaptability of the patient's needs and requirements. The practitioners are not well trained enough to perform all these technologies, which sometimes are really too sophisticated, reducing the usability of them. And last but not least, there is definitely a lack of conclusive scientific evidence that they really work in the rehabilitation field. So what are their unmet needs today? Again, lack of scientific evidence. So we need extensive pragmatic clinical trials. The clinical translation programs has to be wide programs. Some hospitals still lack of adequate information systems to share the information. And there is an interaction between patients, caregivers, policymakers, health professionals, and of course, payers, because this is important to know, as I said before, that may be very costly. And so another problem, in different countries, we have very, very different needs and technologies. So we do need to know that. Now, after this general introduction, let's go to what we can do in a practical way. And I'll talk about first sensorized disease monitoring and then the robotic treatment. This is the use of the GAITRite, which is a quite simple way of evaluating the ability of a patient to walk. In this study, we, of course, used the regular, outcome measure like SPB, Berg balance scales, 10-meter walking test, 6-minute walking test. And as you can see, I can't point, but NW means normal walking. FW means fast walking. DT means double task, so the patient is walking while doing something else. And as you can see, the GAITRite is able, in a highly significant way, to differentiate between CMT patients and health controls. But more importantly, these evaluations, these technical evaluations, do correlate with the clinical outcome measures that we are using. To conclude, the GAITRite system is sensitive to discriminate between patients and controls, highlighting that the gait abnormalities are consistent with previous literature findings. The correlation suggests a potential utility for objective, we need numbers, gait assessment in CMT management, and of course in the evaluation during follow-up. As a matter of fact, we are doing now the longitudinal study, which is very important to see if this technique is able to detect changes over time. Let's go to the hand. The hand is very important, and we have this hand test system, which we tested first many years ago in CMT patients. And as you can see, healthy controls do perform much better and significantly better than group 2, which is CMT patients with an affected hand. Group 1 is CMT patients which are not, aware of any difficulty with the hand, and they perform in the middle. And if you look at the standard deviation, there is a higher standard deviation, meaning that this technique, this is statistically significant different, meaning that this technique, particularly using some way of evaluating like maximum velocity task, is able probably to see the group of patients which is more suitable to start early rehabilitation, and hopefully in the future also some pharmaceutical treatment. Another important point that we saw in this paper is that whereas healthy controls perform significantly better with the dominant hand, there is no difference in patients between dominant and non-dominant hand, meaning that probably there is also the overwork quickness issue here to be considered. So rehabilitation is very important not to exceed with exercising and avoid supermaximal exercises and educate patients to prevent incorrect movements. And now we are using, we just finished the work now, which has been submitted recently to a journal, in amyloid patients. Here we have healthy group, FP0, which is amyloid patients with normal clinical everything, and then an increasing worsening FP1 and FP2. We used baseline assessment, the regular ones, and the hand test system. And again, it was absolutely possible to differentiate patients from healthy controls. Here we were trying, because we have a therapy here, so what we were trying to do is to detect if there was a difference in the FP0 subjects compared to the healthy controls, and we did find it. There is just a little bit more standard deviation. So we basically failed in demonstrating that, because that, again, would be a marker for starting as early as possible the therapy. We don't still have the result of the longitudinal study. We just finished the longitudinal study. So maybe the longitudinal study will be able to give us some more information about the FP0 patients. Anyway, again, the HTS was nicely correlating with the other clinical outcome measures regarding the hands. Let's go to robotic rehabilitation. So this is what we are doing now. It's, it's at the beginning, but what is important to notice that these are actually not just one, pragmatic clinical trials. So really clinical trials which are in the, thought to work in the setting of the real-world health system. And this has been founded by PNC and PNRR in Italy, by our Minister of University and Research, and we basically have two programs. One in acute neuropathy patients, so Guillain-Barré, mostly Guillain-Barré. And then B in chronic neuromuscular disorders, and CMT is one of them. And in the protocol B, we will evaluate the impact of robotic rehabilitation in improving balance, also studying some biomarkers like sarcopenia and improving fatigue. Of course, it needs to be a general collaboration between different clinical and research centers. Here is, in the round circle is the University of Genoa and the San Martino Hospital, besides all the other centers involved. This is the scheme we are at the time of screening now. Then we will randomize our patients, and they undergo technical assisted or techno-assisted rehabilitation treatment and standard rehabilitation treatment, and then there will be a long follow-up, which is very important because we need to know for how long the patient, if they have a benefit, how long this benefit will, last. Let me go back, if I can. Now, it's important to notice that there's been, reported in clinicaltrials.gov, and actually I already received 2 phone calls from abroad for people wanting, to enter this trial, which is, of course, impossible for us. But, it's important to know that it is in the clinicaltrial.gov. So this is the scheme that I don't want to take much more of your time and go through all of this because, I just gave permission to show the slides, so these are open to everybody. Anyway, it's a quite complicated protocol and also not easy to do because of 5 days per week. Working people, for example, may be very difficult for when I see that Mary says yes. It's absolutely true, but we are aware of that. We are aware of that. This is the real world. So maybe we can come out saying, well, it's not feasible for, people working on the days. Guillain-Barré is different. Guillain-Barré, it's acute phase. They come to the hospital, then they go to rehabilitation, and then it will be much easier to do that. For example, we are using ALS patients. You are, applying to ALS patients, maybe they'll be more willing, I don't know. Anyway, these are all open questions. What is important is there is a fixed protocol, to compare using different technologies. Important also the VRRS, which is the virtual reality protocol. And then this is the standard rehabilitation treatment, joint maintenance, muscle strengthening, balance, upper limb function, aerobic training. And then another protocol that we are applying, and actually this protocol is almost it's actually at the end, and it's the NeuroStab, again in the clinicaltrial.gov is listed, and it has to do with balance and gait, which are frequently affected in neurological disease, and especially in neuromuscular disease, and especially in CMT, so that the patient has to develop a postural compensation. It's important to investigate the body center. So there are several different features regarding balance which has to be evaluated and maybe can be the objective of rehabilitation. We used this special type of platform, it's called the GAITRite, which gives the patient, and you also, because I tried it as a normal control, and it's not easy, also, the perturbation of your balance by anterior tilt and anteroposterior tilt. I'm not spoiling the results because Mary Hamedani will present the results of the treatment in a poster. So, just to go quickly to the conclusion, of course, there will be an enormous increase of devices and also of marketing. So this is an important also issue as far as marketing is concerned, and we must be very careful in using all this money in a good way and in a way which really goes back to the patients. Also, it's important to know that there are a lot of small IT companies and startups. In Italy, there are a lot, maybe around Europe too. And, you know, young people are investing in this technology to, produce better results. So the take-home message, am I on time? Yes, you are on time. Okay, perfect. So the take-home messages. We have to remember that these are not anymore, fantasizing technologies, but we can transfer them to the patients in a practical, pragmatic trials to have the scientific answer. Is it useful or is it not useful? Maybe it's not useful, I don't know yet, at least from my experience, And then just the last slide to thank, everybody. I don't know if I can start the movie. Can you start the movie? Maybe in the back. There is a very, very short 11-second movie showing our robotic area in the hospital. Because I can do it from here, I think.
It's possible from the rear.
With the mouse. If you click on the, okay. Yeah, exactly. So this is, and of course I thank the sponsors which made this possible, also some private companies which made this possible, and all the people working with us in this facility. And thank you very much for your attention.
Thank you very much, Angelo. We have one question on the rear, and Mary, second one. On the rear, the first one was the last row, or no, over there. Yes, these women.
In your trials to test the patients, it's nice to see that you have different...
Can you give me the phone, because I can't hear. I have the flu, so also my... Typical disease.
It's about the testing.
Okay.
And we once tried a test with students, and they are changing the results extremely. And it's just laying a mat, like a gymnastic mat, on the floor you have to walk on. Because people with neuropathy, with CMT, they say they walk like on smooth material. And we tried this out. And if you give smooth material under their feet, it changes quite a lot in their movement, and it changes quite more. So I think it's easy to do, and maybe you have one more factor in finding out your aims.
Absolutely. We use, for example, patients wearing orthosis or not wearing orthosis. Of course, it's very important to know that. And, orthosis are important. I think you were speaking about that. So something helping the patients to walk, and it's important to know that while in the time that you are testing and proposing the treatment and applying the treatment.
Okay, thank you. Now, Mary Riley here on the left.
Thank you very much, Angela. I think one thing, you're absolutely right, that we've kind of not been as good at hands as we have with feet over the years, particularly that becomes a real issue for hands in middle age. And I like your glove. It's a very specific question to your TTR study. How did you allow for the fact that 70–80% of people have carpal tunnel syndrome, even if it's subclinical? So they already have carpal tunnel syndrome that might affect the function.
You mean the median, the carpal tunnel syndrome?
So it's very common, even subclinically, in TTR. So it must be a major confounder.
Yes, we take account of the carpal tunnel syndrome, which is most of them has the carpal tunnel syndrome. So we take account of this. Still, in the FP0 patients using the glove, we didn't see a difference.
Okay.
The more affected ones, yes. But again, what we would like to see is the longitudinal evaluation, because it's much more important, than the cross-sectional evaluation, because as you were saying, in the cross-sectional evaluation, you may have subtle changes which, are not really representative of what is going on. And longitudinal is 6 months, Mary? Longitudinal? 6 months and 1 year. And 1 year, okay. So that's our goal, actually. Go to the longitudinal observation, which we are finished right now.
Thank you. There is another question over there. Yes, please.
Thank you, Angelo. And it's very exciting to see how this is used in rehabilitation. As you know, that's my interest as well. A broader question: do you think, because of how long it takes us to do these trials, that actually the technology is moving so quickly at the moment? Are we on catch up the whole time? Do you think? And because it just
no, you're absolutely right. Yeah. I said everything bad about technology, not that it is changing. In 3 months you have new robots, new sensors, and so on. No, you're absolutely right. We have to keep in mind that, and be always update on that. So it's important to know all the different facilities. Have a survey, seeing who is able to offer these technologies, and follow that over time.
But I wonder if we start, as we're starting to understand the mechanisms that these devices and approaches do, and we sort of know what other technologies might do, is there a way of how we might look at other ways of assessing this that isn't the very traditional RCT type approach? Should we look at things like how we use knowledge mobilization, how we might use quality improvement, different paradigms? It's probably a bigger question, but I think otherwise we these technology companies are moving so fast, and they're just going to put it out there without us really evaluating it. I just wonder if that's...
No, well, I think you're right. We have also to develop new way of evaluating the efforts and so on. Of course, this is our robotic area is not just for CMT or chronic neuromuscular, for post-stroke patients, which is a completely different situation. In some ways, like Guillain-Barré, it's an acute condition in which you treat the patient at your best, and then basically the patient, is doing better. So, of course, this is, applied to different type of neurological patients, but definitely we have to improve our way of evaluating it.
May I have a very short question? How do you match real world, you mentioned real world several times, with telemedicine, the patient at home, for doing these kind of approaches? How you imagine?
No, you're absolutely right about that. Telemedicine, we tried telemedicine. Still, at least in our hospital, we don't have a sufficient, technological organization to contact patients, and on the opposite, they do not have enough technical knowledge and instruments to be in contact. So we do some, for example, for headache. Headache is easy to evaluate over time because of the treatment, and with neuromuscular disorders, it's much more difficult for sure, and we have defined it much better in the future. Liguria, for example, is a typical example where you have a big city, and then you have a lot of surrounding, areas very far from the city. So telemedicine, if well organized, would be very important to avoid the patients to travel from the faraway small cities to the center of, to Genova.
Okay.
Maybe.
Thank you very much.
Thank you.
Mike, you have a last question?
Yeah, thanks, Angelo. That was a lovely talk. When you're talking about your longitudinal studies with the Gait Analysis, for example, it will be interesting to see how they change over time, but I think it'll also be interesting to see how they change over time in comparison to the clinical outcome measures we use, because an important question is, will this be more sensitive to pick up change than what we're already doing?
Yes, thanks, Mike, because this is one of our goals, to see if you can, quantify through the GAITRite, the walking defects, then you have numbers to compare and maybe more sensitive to change. And you have to increase also the number of patients, of course. With these were just few patients, 20, 25 patients. But it is an important point. Are these technologies able to detect small changes over time and then be used as an outcome measures, for example?